Hello, this is John Meara from the program in Global Surgery. I would like to talk to you about the evolution in global surgery in the recent 5 or so years and the accomplishments that have been achieved through tremendous community effort. I'd like to start in 1980 to bring you up to the current time, but back in 1980, Dr. Halfdan Mahler, who was the Director General of the WHO, he was really the first global leader who linked global surgery and health equity and social justice. He said the vast majority of the world's population has no access whatsoever to skilled surgical care. He said, I beg you to give serious consideration to this most serious manifestation of social inequity in healthcare. This was really the first time that a global leader had linked surgery and health equity. In 2008, Jim Kim and Paul Farmer wrote a landmark paper in which they described global surgery as the neglected stepchild of global health. This was the first time that global health leaders outside of surgery had really used such a strong description and such a strong metaphor for the issues surrounding lack of access to surgical care. In 2015, this was a landmark year. The World Bank published the Disease Control Priorities 3 9-set volume, and the first volume was on surgery. The Lancet Commission came out with the Lancet Commission on Global Surgery, and the WHO World Health Assembly Resolution 6815 was passed, which recognized surgery and anesthesia as part of universal health coverage. Just to review the Lancet Commission briefly, there were several outputs from the Commission, and the first was a vision: universal access to safe, affordable surgical and anesthesia care when needed. Second thing, there were 5 key messages. The third major outcome was 6 indicators that should be tracked to show progress in global surgery. And the last important output was the concept of national strategic planning, so national surgical, obstetric, and anesthesia planning. And I'll review all of this with you briefly. So the 5 key messages. One message was around access, another, how many procedures needed to be performed, a third dealt with financial risk protection, a fourth talked about the investment needed and what the return could be. And the fifth was a quote from Jim Kim, who was the president of the World Bank at the time, and he said that surgery is an indivisible, indispensable part of healthcare. Now let me go into these key messages a bit more. Key message 1, 5 billion people lack access to safe, affordable surgical and anesthesia care when needed. Now, why is that? Well, there are different aspects to access, and part of it is a timeliness component. So can you get to surgical care if you need it? If you get there, does the hospital have the capacity? Is it a safe facility? And very importantly, is it affordable? And so patients metaphorically have to jump through these types of hoops to get to surgical care. So you cannot define access in one of those domains. You really have to look at all the aspects of access. Now, if you do that, and you look at a heat map, and you see in this map, the dark red areas are regions of the world that have 97, 98, 99% of the population that really does not have the same kind of access that you and I have to surgery and anesthesia and OB care and all the various forms of surgery. Key message 2, 143 million additional procedures are needed in low and middle income countries. That's an amazing number, considering that right now there are about 330 million procedures in the world each year. Now, why is that? Well, the poorest 1/3 of the world's population only receives 6% of the procedures. So it's not that the world is necessarily doing too few procedures, it's that the distribution is off and that low and middle income countries require more surgical access. We also looked in the Lancet Commission at surgeons, anesthesiologists, and obstetricians. And if you look at this graph, you can see what we call the SAO provider density. And on the x-axis, this is the number of providers per 100,000 population. Now you look at various countries, and we looked at the World Bank data and compared certain outcomes like life expectancy or under 5 mortality with the provider density in terms of surgeons, anesthesiologists, and obstetricians. Now above 20 SAOs per 100,000, you can see that World Bank outcomes improve. Below 20, these are countries that really have very poor health outcomes in a number of domains. Now, This does not prove causation, and I don't mean to imply that simply by increasing surgeons, obstetricians, and anesthesiologists from 5 to 15 or 20 that a country magically solves all of its problems. But it gives you an idea of what countries look like that do perform at higher levels of health outcomes. The third message, 81 million people face catastrophic expenditure seeking surgery. That's amazing. 33 million face catastrophic expenditure paying for surgery. 48 million face this just by arriving at the facility, by paying for food, travel, etc. So there are healthcare costs and there are non-healthcare costs that contribute to financial insecurity. Key message 4, investing in surgery is affordable, saves lives, and promotes economic growth. And this is a very important message because historically people have worried that, well, maybe surgery is not cost effective. Turns out that it is very cost effective. And we modeled in the Lancet Commission what it would cost to scale up low and middle income countries to a mid-level and acceptable level of surgery. And that number was a bit staggering, $350 billion over 15 years. However, when we also modeled the economic return, the economic benefit, that number was on the order of 12 trillion. So you can see that this is an investment. This is an investment in people, an investment in human capital, and investment in economic growth. Key message 5. As I mentioned before, this was a quote from Jim Kim where he said that surgery is an indivisible, indispensable part of healthcare. And of course, surgery means obstetrics and anesthesia and nursing and the entire surgical ecosystem. Now, let me talk just for a moment about the indicators that were chosen for the Lancet Commission. So 6 indicators were chosen, and these were indicators that ideally are collected at a national level, and they will show improvement in surgical infrastructure and surgical outcomes. So you can see the first is 2-hour access to surgery. So what percentage of a population is within 2 hours of a facility that can provide safe surgical care? What is the surgical workforce? That's number 2. What is the overall surgical volume in a country? That's number 3. Number 4 is something called perioperative mortality. So really the most basic safety indicator. Who is dying after a surgical procedure? And then the 5th and the 6th really have to do with financial risk protection. So these have to do with impoverishing and catastrophic expenditure. Now, the good news is that the World Bank World Development Indicators accepted these indicators, and we are now in the process of working with them to collect this data. Some of these data are actually on their website now, so you can visit the World Bank World Development Indicator site, WDI section, and 4 of the Lancet 6 indicators are now present on that site. Now I'd like to just focus on one area of the many areas around the world that have done some wonderful things in data collection. The Pacific Islands, and this is an interesting case because the Pacific Island leaders got together and collected all 6 indicators together as a group. And they published this data in the BMJ Global Health. And they published all 6 indicators, and they benchmark against each other. So this was really interesting in that they were open enough and transparent enough to say, let's look at the different countries, the different Pacific Islands, and see, for example, how do we compare in bellwether access? And you can see from PNG to Nauru the different type of 2-hour access that they have. How do they compare in terms of surgical procedure deficit? Now, something like this is very important because if a country wants to make a strategic plan, they need to know what is our workforce deficit, and over 10 or 15 or 20 years, what is our target? They even started to do something very interesting, and that is, could they look at surgical volume and perioperative mortality, and was there any relationship? And in their data, it seems to show that there may be some correlation between surgical volume and perioperative mortality, in that the countries with higher volumes seem to have lower mortalities. Now, is that statistically significant? No, not yet. This is not enough countries to really prove that. But this is the type of data that over time and with a greater number of countries, I think we will be able to find certain correlations that are meaningful and can help with policy. Now, the other area and the other outcome from the Lancet Commission is the concept of strategic planning. and this has become known as NSOAPs, National Surgical, Obstetric, and Anesthesia Planning. And this has 6 domains: workforce, service delivery, infrastructure, information management, finance, and government. Now, these are not cookbooks, and this is not a directive to countries. This is a strategic framework that allows countries to think through, where are we now vis-a-vis surgery? Where do we want to be in 5 or 10 or 20 years? And in various discrete domains, how do we analyze these? How do we analyze our workforce? How do we look at service delivery, etc.? And how do we make priorities, and how do we set goals for ourselves? So you can see this is a concept that has really taken off, and you can see what happened starting in February 2015, where in one of the Lancet Commission meetings, we came up with the concept for National Surgical Strategic Planning. And you can see every year since then, more and more countries have gotten involved. And even recently, for example, the South African Development Community health ministers passed a resolution that they wanted all countries, all 16 countries in the South African Development Community, to have this type of surgical strategic planning. Here's one example from Tanzania. They did a wonderful job, and you can see pictorially here what they did. They worked with stakeholders, clinicians, civil society, government, and they had a technical workshop with a wide range of participants. They roughed out a document that they took to a writing group. That writing group then distilled down all of the feedback from all of the participants. And then this was taken to the Ministry of Finance for costing, and then a final draft was shared with stakeholders. So this was a year-long process. They went through a very specific process to involve all stakeholders. And this was really the government setting priorities. So I want to be clear that this is something that has to be led by ministries of health, by governments. These are not external priorities. This is a country that looks at its own situation and decides on its own priorities, and really just uses this NSOAP framework as that, a framework. And it's a tool that helps a country think through how do we address all of the 6 domains, and how do we prioritize. But ultimately, the priorities and what they prioritize is really up to the country. Here is an example of the Tanzania National Surgical Obstetric Plan, and this is Permanent Secretary Mpoki, who is giving it to one of his colleagues at one of the SADC meetings. And you can see 3 more countries in Africa have also created plans, and this is what led to the South African Development Community passing that resolution. And you can see here an example of the countries in the SADC region. Now, something else which has happened to bring stakeholders and communities together is meetings in Dubai with the Harvard Dubai Center. And these have brought together a wide range of participants from primarily the EMRO and the AFRO and the WPRO and Sierra regions. And I want to just show you, first of all, a video for one of the Dubai meetings that Dr. Tedros from WHO made for the meeting to introduce the participants to the upcoming meeting.
Lord William Tangi, Professor John Meara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen, greetings from Geneva, and thank you for the invitation to speak to you today, and I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than $12 trillion. As part of WHO's transformation, We will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world.
So you can see how Dr. Tedros did a wonderful job summarizing the importance of health system strengthening and incorporating surgery, obstetrics and gynecology, anesthesia, all of the specialties of surgery, all of the cadres of workers into health system strengthening, universal health coverage, and the SDGs. Now, one of the byproducts of the Dubai meetings was further interest in various regions of the world. As I mentioned, EMRO and CIERO and WPRO. And we saw the Western Pacific region really take a leadership role here. Dr. Kasai, who's the director of WPRO, has been a very strong leader. And as I mentioned before, the Pacific Islands have also, in parallel, shown tremendous leadership, first in assessing the Lancet indicators and now moving on to national surgical strategic planning. So this slide shows you a picture from the 72nd World Health Assembly meeting in Geneva. And Dr. Kasai is at this meeting, and this is where he decided that this was a critical and important aspect to regional health planning and that he wanted to incorporate surgical system strengthening in WPRO. And so that led to the WPRO annual meeting, the regional committee meeting in Manila in 2019. And you can see several slides here. This is a picture of the meeting. And in this slide, this is interesting because I've highlighted in yellow some of the narrative that is now incorporated into their official regional plan. And this is narrative that has to do with surgery, OB anesthesia, surgical system strengthening that was never there before. So you can see several areas highlighted that specifically include surgical care in all of its various forms. And here actually is some social media. So this is Dr. Kasai, his own Twitter account, showing a photograph of some of the leaders that were at that meeting. And this is Dr. Corinne Capuano, who also works in the WPRO office with Dr. Wanga, who is the Minister of Health for Fiji. Now, this has led to a number of countries beginning this surgical strategic planning process. And you can see in this map of the globe the colors of the countries who are involved and where they are in the process. So some are just beginning the process, some are finished with the actual strategic planning process. I think it's also important to know, what tools are available. And so what we've done in the program in global surgery and social change is we have all of the tools freely available. So if you go to our website under the NSOAP section, you can have free access to any of the tools that have been used. And the other thing that we have done with the permission of all the countries is we also have all of the documents and final plans that a number of the countries have come up with so that other countries can look at these and get an idea of what various countries have done in terms of their planning processes to adopt and what can be used in the next country, for example. So in summary, I think there are several important themes with national surgical obstetric and anesthesia planning. One is it's important for universal health coverage. Two, it must be integrated into national health plans. So these should not just be documents or plans that sit on a shelf. These are really strategic planning processes that must be woven into a country's national health priority setting and budgeted for, and they should be business plans that are attractive to external funders, multilateral funders, and a country, they should be compelling enough plans that a country wants to invest in them themselves. The third concept is about regionalization. So this is a means of learning from one another. So I think the move that the SADC region took was tremendous because they don't want all 16 countries to do this in isolation. And it's best if they work together. There will be various learnings from one country to another. So I think this is a very good leadership move, and I think it's something that other regions can look to. And the last issue is impact measurement. So it's fine to come up with plans, but it's really critical to weave in impact measurement to see how are these plans being implemented and how are they helping to change health outcomes. Ultimately, it is about health outcomes. So with that, I'd like to thank you. We've summarized a brief history of global surgery starting in 1980, more specifically looking at the last 5 years and what's happened since the Lancet Commission. And then we looked at indicators, the key messages that came out of the Lancet Commission. We also looked at the National Surgical Obstetric and Anesthesia Planning Process, which is a strategic planning process, and how important it is to integrate that into national health plans. It's critically important that they are integrated into national health plans and are not a vertical intervention. So with that, thank you very much. It's been a pleasure to discuss all of this with you.